it's impossible, so.
Good afternoon. Good afternoon. My name is Antonio Wolff. I'm a medical oncologist at Johns Hopkins. Welcome to the San Antonio Translational Controversies version of 2024. We have a wonderful panel. I'll introduce them in a moment. Over the next, we have about 1 hour, and we're going to try to stay on time. You will be able to send your questions using the QR code that is showing right there. So if you want to go online and scan it quite quickly. We're going to have 4 presentations with questions at the end, and I apologize for the crazy slide. I'm sure it's my fault. The first half is going to be how to define triple-negative disease, Drs. Dent and Perou. The second half is going to be on tumor-agnostic drug development, and Drs. Meric-Bernstam and Andre. And so let's talk for a moment, try to put things into context. These are topics of great interest, and I thank the organizers for thinking about putting this together, and we have a wonderful group of speakers. The first half, clinical relevance, how do you define triple-negative disease? What are the additional markers needed in clinical trials and in clinical practice? Does triple-negative disease change over time in the adjuvant and metastatic settings? And what to do with ER-low tumors. Dr. Perou will touch on that as well. Do all ER-low, meaning ER expression 1 to 9%, do they all behave similarly? The second piece is going to be on tumor-agnostic drug development. Why should we launch genomically directed trials of single-agent and combination therapies, trials that avoid traditional histologies but think about more of the biology? Are there guidance from European and US authorities? Are there lessons from industry trials? And finally, a provocative conversation about should we change the way we name and think about cancers? And at the end of the day, this is what this is all about, why we are here in San Antonio. What does it all mean for how we take care of patients? So with no further delay, I'm going to invite Dr. Rebecca Dent from the National Cancer Center in Singapore to get the ball rolling.
Thank you so much, Antonio, and I'd really like to thank Antonio Wolff and the Scientific Committee for this fantastic controversy session. I'm going to start with how to define triple-negative breast cancer. And so I think don't want to worry you, Antonio. I'm not going to go through this paper, but I think this paper really does highlight how far we've come in triple-negative breast cancer, how far the technology's come to really dissecting out what is triple-negative breast cancer. Now, some of you have not been along the journey to understand that triple-negative breast cancer really has been a diagnosis of exclusion. So it was really in the 60s that we finally realized we have this ER receptor-positive breast cancer, and then it took into the 90s to basically come up with some criteria as to how to define ER-positive breast cancer with the sole purpose really to develop therapies that target this ER-positive subtype. Then we have HER2-positive breast cancers, but again, IHC defined, and so triple-negative was really defined by what it wasn't rather than what it was. So we have immunohistochemistry, this indirect measure of ER signaling. And I really just want to highlight this, and again, for those of you that haven't been around, because if you look at the last 30 years, we really refined our ability to define breast cancers using IHC. We have ALLRED, we have H-scores, all that have been optimized, not only looking at percentage of positive stains, but looking at the amount of staining. And why this is so important in terms of measuring indirect signaling is that it's actually improved over time. So what I would argue is that if you look at 1990 stains of a triple-negative breast cancer and compare those to 2025, you might wonder whether some of those are actually, even though we define them as an ER-low triple-negative, may actually look a lot like the one that we saw in 1990. What it looked like for those of us treating triple-negative 20, 25 years ago, when you saw a patient, you saw ER-negative, PR-negative, HER2-negative, you knew that these patients were not going to do well. I want to thank Chuck Perou and his colleagues for the first-generation microarray assessments, basically telling us there was this basal-like subtype that was often ER-negative and HER2-negative, and it had a poorer prognosis. I remember back then, this is the font we used to use. It was very popular there for a while. And we would sort of say, okay, we have this subgroup of triple-negative breast cancers. And I remember like it was yesterday, we'd say, okay, we have these triple-negative, and they're triple-negative but not basal. And then we have these others that are basal but not triple-negative. But we really had trouble defining what is triple-negative breast cancer. And so it's really become this diagnosis of exclusion. And adding to this, I now work in Singapore. I've gone many places around the world. But we lack quality assurance standards, which add to this complexity of trying to define triple-negative breast cancers. The antibodies themselves, we don't have standardizations for this. And then there's the idea that IHC is subject to human error. We've seen this in a lot of the clinical trials where we've had to verify local versus central standardization and results, and we see differences. In addition, there's this lack of standardization of the functional protein. So Chuck and I had a chat a couple of weeks ago, and I said, well, why are we still asking how do we need to define triple-negative breast cancer? And it's really because it was initially defined by what it wasn't, not by what it was. It was an easier way, basically, to identify the majority of patients seen in our clinic with bad biology to decrease the risk of relapse in the curative setting. So it allowed us to lower the threshold in which chemotherapy was indicated. So in this way, TNBC was prognostic because many studies had shown at that time this rapid rise in relapse in the first 3 years after diagnosis, kind of like the acute leukemia of breast cancer. And what was also interesting is that a lot of the studies that we have on breast cancer, looking at the benefits of chemo, we're looking at breast cancer as one group. But what we found is that when we retrospectively went back, this is data from Marco Coglioni, he showed us that this was all driven by the triple-negative subsets. So the 10-year DFS, looking at, this is classical oral CMF, the absolute benefit of chemotherapy was 57 versus 73% in the triple-negative versus a very modest benefit in the ER-positive. So all driven by that triple-negative subgroup. So we've had a lot of progress in triple-negative. So from 2007, 70 to 75% recurrence-free survival, but when we give multi-agent chemotherapy and potentially immunotherapy, this has increased to up to almost 90%. So I'm grateful to Antonio Wolff and the ASCO-CAP guidelines who recognize really the importance of tightening this definition. More importantly, that these specific thresholds really were there because we were trying to identify patients that would benefit from ER-directed therapies, which is very different than modern day, where we're using ER-positive as both a prognostic and predictive factor. And so they came up with this new reporting structure of looking at these ER-low positives. Several groups followed, ESMO guidelines, NCCN guidelines, as well as the ABC guidelines that went as far as to say that these patients should be included in clinical trials, especially for advanced breast cancer. So looking at a very large data set, this is almost 40,000 women from our German colleagues. I want to highlight here, when they looked at ER0 and 1 to 9%, they behaved very similarly. Compared to our patients with ER greater than 10%. You can see differences in local recurrence, lymph node recurrence, and distant recurrence. So you see these lines come together. The ER low and 1 to 9% behave very similarly. When you look at PAS-CR, this is work from Priyanka Sharma, who showed us that the PAS-CR rates, again, were very similar between ER low versus ER 0. So much so, when she did her neoadjuvant single-arm phase 2 trial, looking at the added benefit of an anthracycline-sparing chemotherapy with immune checkpoint inhibition, she included patients that were ER 1 to 9%. Again, our Dutch colleagues have similarly shown us, looking at ER weak looks similar to TNBC. So overall response, overall survival by response to neoadjuvant chemo looks very similar. Now, one thing that they did point out for us is that one difference between the ER weak and the ER low is that the ER zeros had a higher Ki-67, more were grade 3, and of interest lower lobular histology. In addition, our Dutch colleagues have shown us that the immune landscape of ER low and ER intermediate tumors similarly mimic triple-negative breast cancer. And this has been confirmed looking at the two keynote trials looking at immune checkpoint inhibition. You can see it's the ER low patients versus the ER less than 10% versus ER high. Those ER lows gain particular benefit from the benefit of immune checkpoint inhibition. Similar results were seen with nivolumab. Again, in this neoadjuvant context, the patients that were low ER seem to have the greatest benefit. And finally, the Swedish cohort study. Now, why this is so important is that our Swedish colleagues, for years, they never changed their guidelines. 1 to 9% has always been included as their definition of triple-negative breast cancer. And so they give us a fantastic cohort to follow these patients longitudinally. And what you see here is that patients with low disease had a borderline significant better prognosis than those with ER0, but a very small difference, and a small percentage of them did receive endocrine therapy. So in these low TNBCs, there are about 2% of them. We can see that they have similar prognosis and outcomes. Chuck Perou is going to comment on some of the morphological, molecular, and biological features. But what's really interesting is that many trials have started to include these patients. So TNT was Andy Tutt's Taxotere versus Carbo in the metastatic setting, included these lows. And then some of our more recent trials looking at ADCs, Ascent-05 and Tropion-04, 1 to 10% has been included, and the FDA recognized this as a definition of triple negative. Now, what do we do with those patients that are triple negative, low, that we are treating like triple negative, but they have 1 to 9% endocrine positivity? So this is a study from the US. This is looking at a community practice. A large percentage of them are actually ER positive. And what you can see is a large benefit was seen in patients that were 1 to 9%, more than we would have anticipated from getting endocrine therapy. So this is an algorithm that they had suggested, looking at HR status in these triple negatives that have 1 to 9%. So if you have less than 1%, these patients should get chemo and immunotherapy as per Keynote 522. If they have 1 to 9%, you should consider immunotherapy and chemotherapy. And if it's a metastatic setting, if they're PD-L1 positive, you should consider it. And you should consider adjuvant endocrine therapy. And if they're over 10%, obviously include endocrine therapy. Now the issue is this going to confound our clinical trials? Are they triple negative or aren't they? And so I really like this editorial, again, by our colleagues in the Netherlands, who really say there's a lot of actually controversy because a lot of the studies suggest there actually isn't benefit from that 1 to 9%. Should we actually be giving those patients endocrine therapy, and suggest that molecular subtyping might be the way to go in terms of guiding us? So I love this presentation, this eloquent presentation by Christina Curtis yesterday, who really identifies for us this evolutionary continuum with the idea that low is sort of trending down towards the TNBC end of the spectrum. And so it's kind of like a sliding scale. And so I still think we have a lot of work to do to identify who these patients are and do they evolve over time. And in terms of metastatic triple negative breast cancer, I'm not spending as much time here, but I would say where we've learned the most is understanding metastatic triple negative is that these have rapid clonal evolution. So you can see there on the left side of your screen, under the selective pressure of our different treatments, these tumors change, much more so than our positive subtypes. There are some basals that stay the same, but a large majority of them do morph into these different phenotypes, and the agnostic panel will tell us what to do with these patients. So I want to give two cases that highlight our challenge in clinical practice. You have a 8-year-old patient with a 1 centimeter grade 2 triple negative, but the ER is 5%. Node negative, histology is pure apocrine. We didn't have time to get into this, but triple negative does have these subtypes with good prognosis, the adenocystic, the pure apocrine. Would you offer this patient chemotherapy? If you obtain Ki-67, it was 8%. I would argue you probably wouldn't offer this chemotherapy. This was a patient of mine who 10 years later, thankfully, is doing well. Now, what about a 35-year-old patient in your practice who's clinically got a T2N1 tumor, highly proliferative grade 3, ER 6%, PR 0, HER2 0? Would you offer preoperative chemotherapy, the full regimen? I would argue yes. So how should we define triple negative breast cancer? Well, in early breast cancer, I think identifying that it's triple negative, ER negative, less than 1%, PR less than 1%, as well as 1 to 9%, is that if they're high grade, it is reasonable to treat as a triple negative with the combination of chemotherapy, including platinum and immune checkpoint inhibition. But be careful and take special note of the good prognosis subtypes such as apocrine or adenocystic. For clinical trials, I think it is a bit more complicated. It depends on which pathway is being interrogated. And I will defer to the next controversy on treating tumor agnostic. But it's perhaps reasonable to include, I would say, 1 to 9%, unless you're clearly evaluating a basal-like phenotype where a particular therapy is more likely to be effective, or at least power the study to ensure you have the number of what we call true triple-negative breast cancers. With that, over to Chuck Perou. I want to thank many of my colleagues for their slides. Thank you.
Thank you very much, Dr. Dent. This was beautiful, and I think we may even have time for some questions because of the issues. How to handle this in clinical trials can become very complicated. And now we have Dr. Chuck Perou from the University of North Carolina, who's going to give us all the answers.
I don't know about that. I'm going to ask some questions, too. But I'll start by thanking the meeting organizers and Antonio for having me in this session. It's always an honor and privilege to be able to present at this meeting. So here are my disclosures, and I'll talk about that. So forgive me for presenting triple-negative breast cancer within the context of the PAM50 subtypes. And because I think that's going to be informative for how we might design trials. Should we include ER lows? Should we not include ER lows in our triple-negative studies? And how related is the biology is what I'll try and tackle here from a molecular perspective. So years ago, Elise Pratt and myself did this analysis where we had 1,000 tumors that had IHC for ER/PR, HER2, and gene expression. And so we could break them into the clinical bins and then look at the molecular distribution, right? So if you look at triple-negative breast cancers on the bottom left there, the majority is basal-like subtype, right? So I'll always argue when we're studying triple-negative breast cancer, we're really studying the basal-like type if we're looking for response rates in triple negatives as a whole. Conversely, if we look at the basal-like subtype, about 70% of them are triple-negative, but that also means 30% are not triple-negative, right? And those are in our ER-positive studies, those are in our HER2-positive studies, and are largely ignored. And in this publication and others, an ER-positive basal is a basal, right? And typically is not responsive to hormone therapy. And so I think we should pay attention to basal subtype in not triple-negative areas and non-basal subtypes within triple negatives. As is certainly known by most in this audience, in triple-negative breast cancer, here's where the immune system is now extremely important. This is where immune checkpoint inhibitors or inhibitor is approved. And amongst triple negatives, you can go from no immune cells to predominantly immune cells to everything in between. And actually, one of the classification systems for triple-negative breast cancer based on gene expression comes from Powell Brown and colleagues, and it actually has this luminal AR type, which by PAM50 we would call HER2 enriched or luminals. We have a mesenchymal type, and then the basal is split into two groups, one that has basically high immune and another that has lower immune, and this is prognostic. And what you can see on the slide here is that the basal-like type with high immune does best, and the basal-like type that has low immune does the worst. And we definitely should not forget about that basal-like type that's low immune because it's unlikely immune therapy is going to help them, and so we need something different, and maybe this is where ADCs come into play. All right, so here was some seminal work from Christos and colleagues showing many years ago sort of the prognostic, or in this case it's the predictive for pathologic complete response significance of various signatures, including gene expression signatures of immune cell types, which were predictive for all patients, but when you broke it down by clinical type, were basically predictive in TNBC and HER2 positive, but not ER positive. Again, reinforcing this idea of the importance of immune in triple negatives. So if we look at the now strict ASCO-CAP guideline definition, Rebecca nicely introduced this concept of HER2 low, or as we called it in the guidelines here, HER2 low positive, right? So here's tumors that have between 1 and 10% or 1 and 9% ER or PR positive cells. What do we do with these, right? So we saw some data, which is, not very strong about whether they're getting a benefit of endocrine therapy or not. And And so actually, Antonio said, well, Chuck, maybe you should look at this paper. It might help inform that. And actually, this is one of the seminal papers where basically ER was done by ligand binding assay for years, and then Craig Allred and colleagues sort of converted it into immunohistochemistry, which is faster, easier to do, much less tissue requiring. And then here, I believe, is one of the first sort of generation KM plots according to the Allred score, right? Where basically if you're sort of 0 or 2 on this score, this is what's called ER negative. This 2 is where the 1 to 10% positivity is, and this really laid the groundwork for what we're still using today. So when Antonio sent me this, I noticed the senior author, Craig Allred, and I noticed that Craig also sadly passed away this year. And then I looked at the abstract some more and I realized, well, what are they talking about here? They're talking about whether we should give endocrine therapy. And I also noticed that another Craig Jordan, had also passed away this year, one of the developers of tamoxifen. So these are two true giants in the field of breast cancer research. And so why don't we just take a moment of silence in their memory. So moving on to now the molecular dissection of what we're looking at when we're looking at ER low, right? Because I often hear, well, let's just include them, they're bad outcome, it's a bunch of basals anyways. Well, in fact, it's not a bunch of basals, right? So here we looked at, in the top study done by Maggie Cheng and colleagues, we combined together 3 different clinical trials using all clinical subtypes of patients, and then pulled out the ER. In this case, they're called borderline, to look at their molecular PAM50 features. And then we also, on the bottom, looked at the Carolina breast cancer study, pulled out the ER borderlines, looked at their molecular features. And actually what you can see is in the combination of these two, most, by a lot, of the ER lows are not basal. They're luminal A's, they're luminal B's, they're HER2 enriched subtype. And actually in the SABCS study, sort of reinforcing, I think, what a few things Rebecca showed, there's the hint of endocrine therapy benefit in this ER low group. This is not a randomized trial. This is a post hoc look, but it's the red line versus the dotted red line. So it's trending in the direction of there is a benefit in the ER lows. So here is a study, CLGB 40603, a neoadjuvant multi-agent chemotherapy study of early stage triple negatives. We included ER lows in this study. So again, here's the subtype distribution in ER lows. Here's the subtype distribution in the true triple negatives, right? Again, the ER lows are predominantly not basal-like subtype. So we're bringing in more luminals when we actually include the ER lows than I think many of us are expecting. Now, as Rebecca also showed, despite everything I said here, right, the PCR rate between the triple negatives and these ER lows was the same in this study, and the survival was the same in this study. So here's where I'm not sure I'm arguing whether we should include them or should not include them from this slide. And for those who might have an interest, a student in the lab, Brooke Felsheim, will have an oral presentation a bit more about 40603, again involving the importance of the immune system in triple negatives. So of course, now that we have these, what else can we do for triple negatives? So here we just did a simple gene expression plot of some of the drug targets that are being approved and used in this type. PD-L1, top left, PD-1, sort of, what it's acting on, and then actually HER2 amongst these triple negatives and TROP2 amongst triple negatives. And as I think most of us know and appreciate, right? Triple negatives tend to be certainly in the early stage setting, PD-L1 positive. I'm not exactly sure where the HER2 low IHC line would be here, but nonetheless, many triple negatives are HER2 low, and the large majority of them are TROP2 high, except for what we show here is this Claudin low subtype, which by the other triple negative subtyping assays are usually referred to as mesenchymal subtype. So not surprising, right? Mesenchymal, you've lost epithelial features. TROP2 is an epithelial feature. So that group, I'm curious to see what their benefit for ADCs is. So the last thing Antonio asked me to touch on was, in this case, sort of how stable is your PAM50 subtype in a primary tumor to the metastatic setting. And despite the extreme genetic heterogeneity within triple negatives and within basals, on a gene expression level, it is the most stable subtype, right? So if you look at the far left, there's very little changing from basal in the primary to the metastasis. It's almost always a basal in the metastasis. That holds up whether it's a basal that's a triple negative or HER2 positive, where they're much less frequent, or where they're ER positives. And in terms of subtype switching, probably the most plastic is the luminal A, which can change to almost anything else, it seems like, in the metastatic setting. So, if you're starting as a basal, you're probably ending as a basal, or in the metastatic setting, you're unlikely to change to something else. That does not mean your genetic makeup is not changing. It almost certainly is changing. So in closing, ER low positives are mostly non-basal, while true triple negatives are mostly basal. So I'm going to argue if we start including or continue to include ER low positive in triple negatives trials, we're actually making it more heterogeneous. And I'll ask the audience, is that what we want to do? I'm going to say no, right? I think we want to be studying more homogeneous biologic entities so that we can get a better look at response and a better look at resistance mechanisms. Number two, immune features are both prognostic and predictive in triple negatives, particularly in the metastatic setting, where actually PD-L1 is a biomarker. And I think certainly in the early stage and in PD-L1 positive triple negatives, in the metastatic setting, immune therapy is really making an impact and will continue to do so, and we need to keep working on that. As I just showed, intrinsic subtype switching rates are actually lowest in the basal-like and probably lowest in triple negatives, and conversely, probably highest in ER-positive, HER2-negative setting. And I'll just leave with this comment on the bottom here. So, right, when we're designing a clinical trial, always think of the intended use population. Imagine your trial succeeds, right? So if your trial includes ER lows, then you should go for an FDA indication that would have ER lows, not triple negatives only, right? And so, I'll argue, therefore, if you want ER lows in the beginning, they should be there at the end. The tough part is to power studies for the ER low subset is almost impossible. And so it's really a continued question for us to wrestle with. So thank you for your time and attention.
Chuck, this was a beautiful presentation. I think what we are learning is that ER low, we need to be cautious. That is the biomarker we have in the clinic routinely for clinical practice, especially in the adjuvant setting. But when you talk about including them in clinical trials, it is an incomplete biomarker, and I think we need to understand what else is there to avoid the issue of heterogeneity. And I want to thank you for reminding us of Drs. Allred and Jordan. I think many of you may not have met them. I think goes without saying that who we are, what we do today, we are standing on the shoulders of many giants who are no longer with us, and many giants who are still with us and will be with us for a while. We're moving to the second half. I'm seeing wonderful questions coming through the chat. Those of you on the app can see them as well. I don't think we're going to be able to get to all of them, but I think they highlight some of the controversial issues. Moving into tumor agnostic, people like me who are terminally differentiated in breast cancer. I only take care of breast cancer patients. Clinical trials, quote unquote, are a little bit easier. But those of you who also practice other tumor type oncology are dealing with these issues. And we are grateful to have Dr. Funda Meric from MD Anderson Cancer Center to get us started. Please.
Thank you so much. It's really my honor today to talk to you about tumor agnostic drug development. And here are my disclosures. It's been over a decade now where we've been really excited about personalized cancer therapy and really looking at the molecular features of the tumor to be able to identify therapies that would be optimal for each patient. This led to novel clinical trial designs, umbrella trials where we look at a single disease like ovarian cancer, breast cancer, lung cancer, and look at biomarker match therapies. And the flip side of basket trials, looking at a biomarker and enrolling patients with a variety of different tumor types to see if they all benefit. The key concept behind tumor agnostic therapy is if a target is actionable, asking the question of, is it actionable irrespective of tumor type? Two key components. The alteration needs to be found across a variety of tumor types, and then we need to have a drug, obviously, that needs to be active in the context of that biomarker. Basket trial is an efficient way to answer this question because we can look at rare alterations in common diseases as well as rare tumors. Basket trials may be tumor agnostic, may have a single cohort, or it may have histology-specific cohorts as well as tumor agnostic cohorts. We now have had 9 FDA approvals for tumor agnostic therapies, spanning small molecule inhibitors, antibodies, and ADCs. The first approval was with pembrolizumab for MSI-high and mismatch repair deficient tumors. This was a 2017 approval. It was really a major advance in oncology. It looked at a pooled analysis of patients that were MSI-high or deficient in mismatch repair, showing that there was an objective response rate of almost 40% with a very durable response, leading to a lot of excitement. In 2020, the next FDA approval for Pembro came in for TMB-high tumors. This was based on a subset of patients spanning 9 different tumor types. This was supplemented by the fact that many Pembro trials had shown on whole exome sequencing that tumor mutation burden high patients had enhanced activity. There's been a lot of drug development for TRK fusions, in spite of the fact that TRK fusions are quite rare. These trials were designed at a time where it was difficult to do them. Not everybody's doing NGS, not everybody was doing fusion testing. Now we have 3 separate approvals for TRK inhibitors. Loratrectinib that was approved in 2018, with an objective response rate of 75%, durable responses. Shortly thereafter, entrectinib. And this year, we saw approval of repotrectinib, not only showing activity in TRK-naive patients, but patients that have previously gotten a TRK inhibitor. RET fusions are already a well-recognized target, especially in lung cancer, as well as in medullary thyroid cancer, where there are mutations as well as fusions. In 2022, there was an FDA approval for sulfatinib with an objective response rate of 44%. It had been shown in lung cancer and thyroid cancer, now in solid tumors. Across the board, we saw 10 out of 14 tumor types enrolled in a study with a variety of different fusion partners demonstrating objective responses. The BRAF V600E story is a lot more complex. This is the most, one of the most recognized precision oncology targets, and much drug development, both with RAF inhibitors, then with RAF-MEK combinations, and now next generation agents are in development. Several disease-specific approvals have been obtained, and ultimately, dabrafenib-trametinib combination was FDA approved across tumor types with an exclusion of colorectal cancer. This is an interesting story, actually, that, when vemurafenib data appeared, and it was so effective in BRAF mutant melanoma with a 81% response rate in regional studies. Quickly, a study was done in colon cancer that also has a BRAF mutation, and people were very disappointed to see the very low response rate. This actually derailed the whole idea of tumor agnostic therapy for a while. Thankfully, people continue to work on this concept in the lab, and they recognize that when you give a RAF inhibitor in melanoma, there's durable pathway inhibition. In colon cancer, there's a rapid adaptive response, upregulation of EGFR signaling. That led to ultimately the FDA approval of EGFR inhibition in combination with RAF inhibition for colon cancer. Since that time, many clinical trials are now very aggressive and looking at a variety of different tumor types as well as a variety of different genotypes during their phase 1 design. On the left-hand side, you see the phase 1 expansion of futibatinib, a FGFR inhibitor. You can see across a variety of tumor types testing was done. Clear signal in cholangiocarcinoma. Most of those patients have a FGFR2 fusion. Same study had a phase 2 expansion. You can see in the bottom, that data led to the FDA approval of futibatinib in cholangiocarcinoma with FGFR2 fusions. Its tumor-agnostic activity is still being explored in additional trials. Several other studies have started showing that histology and variant differences can occur with small molecule inhibitors and others. For example, when neratinib was tested for HER2 mutations, we saw activity in some breast cancers, not so much in lung cancer, really no activity in bladder cancer and colon cancer. Similarly, we've seen a lot of drug development for EGFR and HER2 mutations, especially in exon 20, and clearly there's a dramatic difference in efficacy with different small molecule inhibitors in this space. When we take one of those agents that seem to be active for exon 20 mutations and do clinical trials, you see that there's quite a bit of variability based on what genotype was enrolled in those studies. So clearly, different drugs have differential activity in the context of different variants. We also keep on thinking about single targets, single treatment, but in fact, the genomic co-alterations also matter. We already knew this from EGFR, but again, we got to re-experience with HER2. Here you see the data for colorectal cancer patients that were HER2 amplified. They got pertuzumab and trastuzumab. Almost all the responders were KRAS wild type. So this ultimately went into NCCN guidelines for only wild type patients. But interestingly, a HER2 ADC still has activity in the context of a KRAS mutation. This year, we've seen the data changing clinical impact with the Destiny Pan-Tumor-2 study asking the question of, do ADCs have tumor-agnostic activity for target expressors? We enrolled patients that immunohistochemistry, 3+ or 2+, with a variety of different tumor types, including another tumor cohort. And you can see the data here showing that in trastuzumab deruxtecan had objective responses across a variety of different tumor types if the patients were 3+. In the central IHC, that objective response rate was 61% for 3+ patients, and these were durable with a median duration of response of 22 months. This, along with the colon cancer data and lung cancer data, led to FDA approval in a tumor-agnostic fashion for 3+ patients for T-DXd. Now, I'm very excited about the idea of tumor-agnostic development for ADCs, but I have to admit this is complex. I mean, we know from T-DXd already that expression required for efficacy may differ by histology. T-DXd has activity for low HER2 breast cancer, but you need 3+ for colon cancer. We know that not all payloads may be active in all histologies, and there's a lot of aspects of the ADC that may affect these features, including the linker stability, the payload potency, the bystander effect. And there's complications with developing tumor-agnostic assays. For example, even an IHC is difficult to optimize across tumor types. We don't know what the minimum expression required or the threshold, or whether we should be using a threshold or a continuous assessment. And ultimately, we want to use assays that everybody is using in their routine practice. We are going to be testing the idea of a tumor-agnostic assessment and using multiplex testing at the ADC match study, the study that will be excluding breast cancer, but will be an opportunity for patients with a variety of tumor types, including rare tumors, will be not only looking at if you have high expression of a target, do you benefit from ADC, but also will be asking the question of, can we do RNA-based testing, thus leverage the already ongoing multiplex RNA testing for clinical decision-making. We talked a lot about single-agent therapy, but we recognize that few patients have a driver that's so strong that you can get durable objective responses with it. The fusions are really an outlier. There are a lot of issues, including many resistant mechanisms such as loss of target, adaptive responses, acquired mutations, and activation of other drivers, including downstream alterations. Thus, there's great interest in combination therapies. Can we inhibit the pathway stronger with vertical inhibition, like we do with RAF-MEK, or can we target co-alterations, adaptive responses, acquired mutations, or combine with standard of care? So that is one of the principles that we're testing in the NCI combo match study. Here we're looking at whether we can enhance activity also by picking combinations that have strong preclinical data demonstrating clearly that the combination is better than either agent alone. However, there are complications with this kind of a study design as well. From a preliminary data standpoint, if you're going to go down to a tumor-agnostic drug development, how many different disease types do you need preclinical data for? How much safety do you need to have to launch a cooperative group study? How do you design these studies? If you have two drugs that don't have efficacy on their own, it's reasonable to start a single cohort study. But if either agent is active, then it's felt that you need to do a randomized study to be able to get the contribution of components.
Then don't ask.
Finally, tumor-agnostic therapies, I think, are really exciting at this time. They increase access to precision therapy for rare tumors as well as rare alterations. It's an opportunity for implementation science because it's common that people don't recognize this FDA approval came in. So as breast oncologists, we need to be on the lookout for these tumor-agnostic targets, TRK fusions, BRAF mutations, RET fusions, and make sure that we also have appropriate testing for this. And we need to continue to look for modifiers of response, be on the lookout for emerging targets that have tumor-agnostic potential. And of course, there's going to be more opportunities coming with new drug classes as well as new approaches for molecular profiling. I'd like to conclude by saying these kind of studies are hard to do and they're really hard to implement. So I'd like to thank my team, the Investigation of Cancer Therapeutics, and our Precision Oncology Decision Support Program to make our program a success. Thank you so much.
Thank you very much, Dr. Meric. And to close, before we go into the Q&A, we have Dr. Fabrice Andre from Institut Gustave Roussy in Villejuif.
Okay. Thank you, Antonio. So we are going to discuss the next step of what Funda presented. So these are some conflict of interests. So the first question is, what would have happened if some common drugs were developed in a tissue-agnostic way? So here I'm going to do some retrospectology. And as you know, it's the most exact science. So I'm just going to pick up some illustration. So what Funda show is that there are few drugs. I don't know if it works. Okay. There are few drugs that have been approved based on rare biological targets, agnostic of the origin of cancer. And she showed that, I think there are 9 approvals in the US. But what has been shown is that all these targets are shared across cancer, and usually they are rare. And we are going to come back on this later. So now we are going to go to another question, that is whether for some common drugs, the drug development would have been different if this tissue-agnostic way were already endorsed. And here the goal is not to say, things should have been different. It's just to give some illustration. So the first illustration, I'm just going to use this one because the second one is a little bit too controversial, and I understand we're in a controversy session, but we had many problems with the other example. So let's focus on this first one. This is the first phase 1 reporting the efficacy of anti-PD-1 antibody. Okay, 2012, so it was 12 years from now. And everything was told as soon as the phase 1. And the phase 1 told that, I should have listened how to use the mouse, but okay. The phase 1 told us very simple thing, that is, when PD-L1 is expressed, anti-PD-1 leads some anti-tumor response. When there is no PD-L1, there is no response. Okay, so what I mean here is that as soon as the phase 1, and it's written at the bottom, the key element, the key driver of, key determinant of sensitivity was defined, and this determinant is a biological determinant. It's not the organ of origin. Okay? And because things are what they are, what we all decided, in fact, is to develop this drug, anti-PD-1, one disease after another one, and then 2023, 11 to 12 years after, colleagues and patients who had endometrial cancer could finally, 11 years or 12 years after the phase 1, got access to anti-PD-1. But the key determinant of sensitivity is exactly the same in endometrial cancer or in melanoma. It's PD-L1 expression, high mutational burden, MSI, etc. So what I mean is that it's the biological determinant of sensitivity that matters. Okay? And so here the question is we all need to think about this question. As soon as the phase 1, anybody who is rational would have thought, look, it's very simple, the drug development. We take any cancer with PD-L1 expression, and we just randomize anti-PD-1 versus not. But not what we did are dozens of trials, each one in each disease defined by the organ of origin. Okay, so this, I just wanted to show first this example, and again, this is retrospectology. Of course, things could not have done that way, but it's just for us to think. Because what we need to think now is how many patients did we have in our clinics with triple-negative breast cancer who told us, doctor, I don't understand. There was a press release in melanoma, high efficacy of anti-PD-1, why I could not have access to this drug? And the only reason is because breast cancer was number 6 in the list of disease that were going to be tested by the trial. But again, the key determinant of drug sensitivity were totally similar between all diseases. Okay, take-home message. Biological features are the key determinant of drug sensitivity. Developing drugs according to biological feature and irrespective of organ of origin could allow a quicker access to therapy. So now what are the two questions? First question is when and how should we perform a tumor agnostic drug development? And the second question is if we think that biomarkers are the key determinant of drug sensitivity, why are we still using classification of cancer that are based on the organ? First question, what are the framework for drug development to develop drugs on an organ agnostic way? First question is, when we do a phase 1, and we include many patients, do we have a tool to screen if this drug should be developed on an organ or tissue agnostic way? ESMO has developed an interesting framework that is telling very simple things based on some analysis of drug development that if you have one molecular alteration defined that works in preclinical model, and if more than 2/3 of the cancer respond with more than 20%, then the drug should have a tissue agnostic development, maybe in addition to conventional development. But this is a very important tool, I will not go into detail, that is replaced at the center of drug development. Again, if your phase 1 is telling you more than 2/3 of tumor, more than 20% response, the recommendation is to go tissue agnostic development because otherwise, 12 years after, again, patients with endometrial cancer will have a phase 3 trial 12 years after all the other patients. Okay, so when feasible, it's important to develop the drug based on the biological determinant of sensitivity and not the organ of origin. FDA has released some guidance, very well done. I'm not going to go into detail. It's very well written. I think any oncologist should read this guidance. I just took 3 points that are point of discussion. First, what is the distribution of the molecular alteration across disease? If one disease has high frequency of the alteration, you should go on this disease and maybe then do agnostic development. Second point, trial design. When the disease, the alteration is frequent, the drug is common, you want to do randomized trial, it's very difficult because each tumor now has a different standard of care, has a different outcome. So running randomized trial on an organ-agnostic way is putting some methodological issues that are real. Again, it's written in this document. I'm not going to go into detail. Point number 3, if we run organ-agnostic trials, what is the spectrum of the disease we are using, and what is the minimal number of patients in each cohort? Okay? 2 additional slides on methodology. What do we call organ-agnostic development? Are we including all the cancer or multiple cohorts, as in this trial for mutational burden, or are we really going agnostic, meaning we even don't know what is the origin of the cancer? We just include the patient irrespective of the origin of the cancer. So this is the first issue on methodology. Okay? The second issue that I think is more important is now we include, like in this trial, a patient based on biological feature, mutational burden. Okay? Mutational burden for efficacy of anti-PD-1. We put multi-cohort. Maybe there is a registration. What happens if in 1 or 2 diseases the drug does not work? Should we exclude retrospectively the disease? Again, these are questions of methodology. Take-home message from this part. Tissue-agnostic drug development is an alternative to conventional drug development and should be more frequently used because we don't want the story of anti-PD-1 to be repeated for each new drug. Some frameworks are available, but it's still work in progress. Okay, it's very preliminary time. Some scientific society are trying to develop this framework. Again, FDA guidance is very useful, but you will see in many points is written, oh, please refer to FDA, come to discuss with us. It means the framework is not stable. Okay? Again, biological feature and not the organ of origin are the key determinant of drug response to modern therapy. And now the next question is, if biological features are so important, well, why don't we change classification of cancer? Okay, so this is the third part. So question is, we have seen with modern therapies, the key determinant of drug sensitivity are the biological features. Should we move classification for patients with metastatic cancer? I'm not talking about early stage cancer. Should we move classification for patients with metastatic cancer toward classification that will classify cancer based on biology and no longer based on organ of origin? It's a little bit extreme. Nevertheless, some scientific societies are taking the question very seriously. ESMO is coming with what they call ITAC nosology. 3 different types of cancer. The first cancer are cancer that are defined by molecular alteration. Tumor agnostic, molecular alteration. Example, today we talk about NTRK fusion, NTRK translocated cancer. Nobody who has seen a patient with an NTRK fusion is thinking about, oh, this cancer is coming from salivary gland or lung. No, it's an NTRK translocated cancer. Okay, so really, now with this new nosology has been introduced the fact that some metastatic cancer are reclassified based on the molecular alteration they present and no longer the organ of origin. Okay, then there are other classifications. I will not go into detail. Okay, take-home message, cancer classification should move stepwise, not tomorrow morning, stepwise to molecular classification in the metastatic setting because, again, molecular features are the key determinant of drug development. Okay? Then, what is going to happen? And I have 1 minute to present this last point. Today, we are thinking 1 or 2 or 3 biological features per cancer. But more and more, biological features, biological characteristics are defining the cancer. And at a certain time point, the molecular portrait will become so comprehensive that we will definitively have some personalized medicine. And I'm just going to introduce this concept of molecular twin. And what are we talking about? We talk about, for each patient, what we are already doing is next-generation sequencing, immunohistochemistry, RNA-seq, PD-L1 expression. So for each patient, in reality, what we are doing now, we are already generating some molecular twin defined based on DNA, RNA, microenvironment, etc. Okay? In the future, it's going to become more and more complex, and each molecular twin will integrate more and more characteristics. And there are two important points. First, each molecular twin is going to be interpreted by framework of classification and generative AI as compared to what we call now knowledge card. And this is very important for all the community in cancer to contribute to what we call knowledge card, is where all this generative AI will interpret our molecular twins. Okay, I will finish on this conclusion. Molecular feature, known or unknown, are the key determinant of treatment sensitivity. When they are shared across tumor type, a tissue-agnostic drug development should be prioritized to speed up drug access. In this situation where molecular alterations are shared between cancer, we think that cancer classification should be driven by molecular feature and no longer by organ of origin. And we have discussed that because we had more and more and more feature, we should move to more personalized medicine and these things of molecular twin. Thank you for your attention.
Thank you very much, Dr. Andre. We do have microphones on the side of each room. If you come to the microphone, introduce yourself and institution. We have a couple of minutes left for a few questions. Let me do some rapid fire with folks in the panel here. Dr. Dent, tell us a little bit, triple-negative disease, does it matter, invasive lobular versus invasive ductal carcinoma? Do you worry differently?
Short answer, we don't know. I think it's not very common. Chuck and I were just commenting that it's a rare event. I would say overall they don't seem to do as well as sort of a ductal ER-positive luminal, but the lobular triple negatives do have a poor prognosis and are harder to treat.
Another question from the app, and I apologize, we don't have enough time to go through the wonderful questions, but a question for Dr. Perou. You showed very nicely that triple-negative breast cancer does not change with time. Why?
I would caution that interpretation as it doesn't change. It wasn't changing subtype, I think, for the basal-like subtype. I think the basal-like subtype is in part determined by copy number changes, including lots of chromosome losses, which you cannot undo.
Very well. Thank you very much. We have one or two questions on that side, please.
First, Mimic HCC, Jordan.
Could you speak a little louder or closer?
Okay. First, Mimic HCC, Jordan. My question about the second case in which she was a high-risk patient, young and ER low. You suggest to give immune therapy. I think this was not supported by evidence keynote 522. And in the light of having data from CreateX, which is Xeloda, adding Xeloda as adjuvant for patients with residual disease. And we don't know the answer, which is better, immune therapy versus CreateX. Both give survival. And CreateX included hormone receptor positive, high and low. So do you think that CreateX could be fit this particular group of patients?
So that's a great question. So I think the first thing is, yeah, we did try to include in Keynote 522 the ER low, but it was tricky. I think the FDA at the time wasn't so keen. They've kind of changed their ruling on that and does allow for it. Keynote 756, as well as the NAVO trial, actually did show us that in those ER low patients, they did achieve more of a benefit, higher PCR rates with the addition of immune checkpoint inhibition. So to be honest, I do think the benefit is there. The other thing is if you actually biopsy those patients over time or even repeat the biopsy, more often than not, that repeat biopsy actually shows that it's negative. The other thing that I wonder if Chuck could comment on is in the data on CREATE-X, none of those patients received carboplatin, and so you don't know the benefit of capecitabine in the context of having prior carboplatin. The other thing is there's some data that suggests that there's differential benefit of adjuvant capecitabine, whether you're basal-like or not, which is not so the case as presented by Joyce O'Shaughnessy yesterday in the subgroup analysis of Keynote 522.
Thank you.
Thank you very much. We have time for one more question, please.
Hi, Hari Nakshatri from Indiana University. This is a comment about the organ-agnostic drug discovery. If you look into the recent papers from Human Cell Atlas, a simple cell type like fibroblasts show organ-specific variability. So it may complicate the drug discovery if you look into all the cell type in a normal organ.
Yeah, thank you. That's something that, of course, we can take into consideration. Definitely, the microenvironment has not been adequately investigated, but of course, in clinical trials, all metastatic sites are being tracked, so needs further study.
I just want to thank all the speakers. We do need to finish now because there's an ACR award presentation beginning immediately in the same room. Next time, we need more time for Q&A. I want to thank Dr. Andre, Meric, Perou, and Dent for a wonderful presentation. Thank you for being with us.
Thanks, sir.